Coronary artery bypass surgery with the heart and lung machine. If the stenosis in the coronary arteries cannot be dilated or stented, or if there are other indications for cardiac surgery, a coronary bypass operation is performed. The median sternotomy is the classical approach. For this purpose, the sternum is opened lengthwise from the xiphoid process to the manubrium with a saw. The vein is removed from the connections between the aorta and the narrowed arteries. Preferences is given to the arterial vessels, which include the right and left thoracic arteries or one of the lower arm arteries. In cases where the patient requires more than 3 bypasses or a jump technique is not possible, the veins are used. In this case, the great saphenous vein of the leg is standard. After the arteries or veins are removed and prepared, the surgeon connects the patient to the heart and lung machine. In doing so, the venous cannula is inserted into the right atrium, and the cannula with the oxygen-rich blood is inserted into the aorta. This ultimately allows the aorta to be clamped and the heart stopped by a cardioplegic solution that is introduced into the coronary arteries. An arrested heart allows the surgeon to rotate the heart to connect the stenosed artery with the veins grafted. When all the anastomosis are finished, the surgeon opens the aorta and the incoming blood flow washes out the cardioplegic solution. Without the cardioplegia, the heart begins to beat by itself. Since the internal thoracic arteries originate from the subclavian artery, it is not necessary to re-implant them into the aorta. Other vessels taken from the arm or the leg are sewn to the aorta to obtain an arterial blood flow to bypass the coronary constriction. Despite the complexity of the disease, portions of the coronary arteries are bypassed for the systemic circulation and the blood flow is restored. After the bypass is performed, the electrodes of the temporary external pacemaker are sewn to the heart and 2 or 3 thoracic drainage tubes are inserted into the chest. The thorax drainage tubes are removed on the 2nd day after surgery and the pacemaker cable on the 5th day. Finally, the chest is closed. The sternum is then wired together and the soft tissue is sutured. After the operation, the patient is transferred to the intensive care unit for withdrawal from the anesthesia. Thus, the advantages of coronary bypass care are the possibility to treat very severe cases. Furthermore, this method has the best long-term results compared with other therapeutic measures.